All right, the time is now noon. I'm sure more people will join in as they enter their lunch break, but I'm just going to get started. My name is Bridget Sweeney, and I'm the training coordinator for the Maryland Addiction Consultation Service. Thank you for attending today's webinar. It is being recorded, and as you may have noticed, both your camera and microphone are off for the duration of today's webinar. It is recorded and you will receive a link to the recording within 1 business week. And if for any reason you don't, it will be up on our website within 1 business week. Immediately following today's presentation, I'll send over a copy of the slides. So please look out for that at the email that you registered for today's webinar with. There's also going to be a little more information about the Maryland Addiction Consultation Service and any other resources that we may share after today. I am going to give a brief overview of the Maryland Addiction Consultation Service. So we are a state-funded program. All of our services are completely free. And we're here to provide support to prescribers and their practices in addressing the needs of their patients with substance use disorders and chronic pain management. So this includes free phone consultation for clinical questions, and those clinical questions can be as specific as you would like. They can be very patient specific as long as you use de-identified information, or they could be broader, for example, about using buprenorphine for pain, which we'll go over today. And we also offer education and training opportunities related to substance use disorders and chronic pain management. So those range from 1-hour webinars that are usually during the lunch break to waiver trainings, which can go up to half and half, which is 4 hours, or a full 8-hour training. And we actually have a full training coming up in February. I'll be sure to put that information in the chat. Our next webinar is going to be on the treatment of complex alcohol use disorder, and I'll put that registration link, which has some more information about that, into the chat as well. We also offer assistance with addiction and behavioral health resources and referrals. We have technical assistance, which helps with practice implementation or expanding office-based addiction treatment services. And something that a lot of people find really beneficial are our Max Tele-Echo clinics. So these are collaborative medical education through didactic presentations and case-based learning. And how this works is it's a group of members of the medical community and a group of panelists, which are our consultants at the Maryland Addiction Consultation Service. And someone from the medical community brings their own case to present to the group. And they get feedback and suggestions for care for that specific patient. That's also, with that comes a didactic presentation. So one of our consultants will present on a topic, and each month it's a different topic. So it's a really great learning opportunity and a great opportunity to get to know your peers in the medical field. And I will put information about that in the chat as well. But before we get started, I also would like to introduce our presenter today. Our presenter today is Dr. Sarah Merritt. And Dr. Merritt is triple board certified physician with ABMS qualifications in anesthesiology, pain medicine, as well as addiction medicine. She attended Birmingham Southern College and medical school at the University of Alabama in Birmingham. And after residency in anesthesiology at the University of North Carolina in Chapel Hill, she pursued additional fellowship training in pain management at the Johns Hopkins Medical Institute. She's well-versed in a full spectrum of interventional and medical pain management techniques, and her practice includes not only needle-based procedures such as epidurals, radiofrequency, and ultrasound-guided injections, but also medical management of acute and chronic pain. She also has a portion of her practice dedicated to treating opioid use disorder, which she'll touch on today. Dr. Merritt is active as a volunteer in the medical community in addition to her medical practice. She was appointed by the Maryland Department of Health and Mental Hygiene as a member of the Technical Access Committee for the Maryland State PDMP. She's also a co-chairperson in the Legislative Council for MedChi, the Maryland State Medical Society, and a member of the MedChi Board of Trustees. We're also fortunate enough to have Dr. Merritt as a consultant at the Maryland Addiction Consultation Service. So anytime you have questions about treating your patients with pain management or anything related to buprenorphine, if you contact the Max line, we'll be happy to connect you to Dr. Merritt. Dr. Merritt, I am going to turn it over to you, and I just have one note. You're currently in presenter mode. But that's an easy fix. So I think if you click use slideshow at the top.
Good. You want me, slideshow's better.
There we go.
Excellent.
Yeah, that's perfect. Thank you so much. So feel free to get started, Dr. Merritt. Thank you so much for presenting today.
No problem. Thank you so much, Bridget, for the introduction. And I'll just reiterate, if you're joining, please feel free to introduce yourself in the chat, what practice you're with, so that we have some opportunity maybe for networking or knowing who else is interested in these topics. I am presenting this topic today, which, pain management is a huge topic, something that touches almost every practicing physician. Pain is the most common presenting complaint. And then, of course, I don't probably need to inform this audience in the time now of the opioid epidemic. It has made some of the treatment of pain even more challenging and presents us at times with new issues. So I was asked to give this presentation in part based on one of the cases. I'm going to present some, I think I've got 4 patient cases just with various challenging pain problems. And Bridget, I guess I don't know what the potential for like discussion with the group is as well, but maybe at the end, of course, please be putting in questions. And Bridget, is that better at the end, or is that something we can do during?
That's up to you. Are you okay if I ask questions in between slides, or would you prefer to wait till the end?
I'd be okay if you ask questions as they come up.
Okay, I can do that.
Thank you. So yeah, feel free to ask questions as they come up. I don't mind kind of addressing things. And if this were an in-person mode, I think that less formal discussion mode can be helpful. And certainly, again, if there are questions that accumulate during the talk, I'm glad to try to address them after. I have about 35 slides, so I think we have plenty of time to get through the examples that I have and then address questions as needed. Because I know that we've all got our own challenging cases to talk through. The other thing I would say is that really, and I'll go to my next slide, really that the other way to connect, of course, is through MACS. So MACS is a grant-funded organization to provide support to prescribers and their practices to address the needs of patients with substance use disorders and chronic pain management. So again, MACS is here for you to help answer questions and frankly, again, as a consultation type of service. So if you have questions or things that come up, even if you've managed it, I personally, before I became a MACS consultant, I had used the service, I had called about things, and sometimes even if I had managed the problem, but I was still interested in some expert input, I think it can be a nice way to engage. So again, the services are free. You can reach out to MACS as listed here by phone. And there are also forms on the website. Oops, there we go. So I just wanted to acknowledge briefly my patients, because the patient case presentation is just an extra, just makes one extra thoughtful about the different cases, the different patients you've seen over the years, and just to acknowledge the patients that contribute to my own understanding of pain and the human experience, frankly. I would imagine that many of you feel the same way, that you can learn so much about doctoring, about the experience of pain through treating the patients. And I'm very grateful for that aspect of the work that I do. So in terms of learning objectives, we needed to come up with some things to make sure we communicate. We want to just have some discussion on short-acting medication and make sure that learners are aware that even patients who might be taking a short-acting opioid medication for pain, they might be opioid dependent. We want to review that addiction or substance use disorder with one substance is actually commonly associated with an addiction or substance use disorder with another. And lastly, and this was kind of half the title because we do want to spend a good bit of time on it. We want to discuss buprenorphine and the use of it for pain, and how you might perform a rotation from, say, a C2 opioid prescription to buprenorphine for pain, and share some pearls for this as well. So I would share that Sir William Osler who was again one of the founders of Johns Hopkins Hospital, is supposedly has said, listen to the patient, and he or she or they are telling you the diagnosis. So I think this makes so much sense in history taking. If we've probably all heard this, but it's to take great care of patients. I think some of what's involved is a lot of listening and processing. And so sometimes, I guess the corollary to this, or the extension maybe of this, is maybe the patient is telling you the diagnosis, right? And in Osler's time, they didn't have the diagnostic tools that we have in terms of radiologic studies and advanced imaging, certain labs, et cetera, that they didn't have then. But I think now the extension to this would be not just he's telling you the diagnosis, but the patient's input may also inform your treatment. And I think that is particularly important to keep in mind in patients with challenging pain problems. So this is something that I like and have shared very often when speaking to an audience that's not exclusively pain doctors. And this is not from the pain literature per se. This is actually from emergency department publication. But I think it's helpful, almost like a stepladder type of thinking, in that it includes these other, it includes various options in terms of pain relief. So again, for mild and moderate pain relief, that you might start with NSAIDs, topical medications, acetaminophen. In acute pain in particular, you might need an opioid. And then when these kind of, basics or fundamentals are not effective, then there's kind of this idea about a ladder or escalation where, you might start to incorporate into your plan other types of agents. So when those basics are not sufficient, these things that we might add on medically would include neuropathic pain agents, possibly interventional treatments like regional blocks, nerve blocks, epidurals, etc. Things like skeletal muscle relaxants, and antidepressants as well that have efficacy for pain. And I wanted to make sure to include that because I think we have a diverse group of attendees, some of whom are prescribers and may be familiar with this concept, and some of whom may not be, but I think this might put in some perspective, why complexity of certain regimens might evolve with the complexity of a pain case, and why some of these things like a nerve block or neuropathic agent might be incorporated. Again, those are things that aren't usually first line, but that are used and needed in cases that are more severe and or more complex. So this is a case that was brought to me that came through the I guess the Max group became aware of, where a patient had presented to the emergency department after getting a dose of Vivitrol. And so this was a patient who came to the ER with shaking and pain all over and chills with onset the same day after his first shot of Vivitrol. And this person's Vivitrol had been prescribed and given based on a problem with alcohol. So over some time, he developed alcohol problems, had loss of control of drinking, sought counseling and treatment, and he was recommended for Vivitrol shot to remain abstinent from alcohol. His medication list included oxycodone, which he was taking at a low to moderate dose, 5 milligrams 4 times daily for pain. He had reported taking it just as prescribed and without signs or concerns in regards to misuse. So in this case, the situation, as you may have deduced by now, is that this patient who was taking an oxycodone as needed for pain, and then was administered administered Vivitrol for alcohol use problems, was actually placed into opioid withdrawal. So I think that in this case, there was just a lack of recognition that the patient was taking an oxycodone or opioid medication for pain. And there was again, a missed interaction that the Vivitrol is long-acting naltrexone, extended release naltrexone that's injected. It lasts a month, and it blocks opioid receptors. In this case, the injected Vivitrol, this extended release naltrexone, the mechanism would be such that it would really displace any opioid medicine from any of the mu receptors. So in this case, that's what the patient experienced. He had opioid withdrawal, and he was able to be nursed through it. He was able to get comfort care and treatment to minimize the effect and the impact of withdrawal, but nonetheless, he had the experience. And of course, the labeled directions on Vivitrol would suggest not using it in patients who are opioid dependent. But I think really the key issue in this case would be that there was maybe a lack of recognition that a patient who didn't have a problem, say, with opioids, or was taking a short-acting medication, might actually still be opioid dependent. So some of the discussion that I would add to that would be maybe to ask, were you taught maybe that opioid withdrawal lasts about 72 hours? And I can say from my own experience that probably when I was in school or early in my training, before I got maybe deeper into learning about pain medicine, I think the things that I were told were along the lines of that, if a patient's taking opioids appropriately, they should be able to just stop them, that opioid withdrawal lasts about 72 hours. And really, if the patient can get through those first 72 hours, that then they'll be okay. And really, I think the reality is that it's more challenging than that. And for some medications, I would say that it's not uncommon for symptoms to maybe peak at 72 hours. That may be correct. But frankly, the experience can be very daunting. The quote that I've heard used is that opioid withdrawal won't necessarily kill you, but it might make you want to die. And that's because, as we know, there are other medications that frankly, are life-threatening, directly life-threatening to withdraw from: alcohol, benzodiazepines, et cetera. There are other examples. And opioid withdrawal in and of itself is not life-threatening. However, there are consequences of it that can be life-threatening, such as for instance, a relapse to opioid use in someone with opioid use disorder, or just, again, I think the idea that it's just so intolerable that it really drives people to have, to seek medication, to, really have a very bad experience. So I did want to share with you this book called In Pain, that's written by Travis Reeder, actually. He was in Baltimore also. A bioethicist at Johns Hopkins, and he had an experience where he had a motorcycle accident and then had a large ankle reconstruction, a lot of damage, nearly lost the foot, and was prescribed opioids for a period of time to manage his pain symptoms. And ultimately, he came off of them essentially by stopping cold turkey. And the book is really, I think, describes a lot of his journey through this process. And I think the loneliness that he felt in dealing with this problem, and frankly, the lack of direction that he had from the medical community in coming off of the medications. And I would say that, some of this may be because We're used to this idea, or some of us have been educated with this idea that, oh, if you don't have a problem with the medications, you should just be able to stop them and it'll be no big deal. And then the reality is that, that the withdrawal effects are significant for mood and pain. And this is a very powerful story if you're inclined to check it out. So I want to present a different type of case. This is a patient that I'm personally seeing now who is struggling with some pain issues. And again, I think in relationship to this first case discussion where that patient who was taking a daily opioid did have a problem with alcohol and got treatment for it, I think it's pertinent to be reminded that having one substance problem is a risk factor or is associated with other substance problems. So again, it's not uncommon for folks to have more than one substance use disorder. And so if you have a patient who, for instance, has had a problem with medication overuse in the past or of one type, say a benzodiazepine, that person could get in a position where they would be higher risk, say, to be prescribed, say, an opioid medication. So again, I think these are important things to keep in mind as you're seeing your patients. In this case, this patient is particularly interesting, frankly, because in the time that I've been seeing her, she's really struggled with use of a couple of different substances, and it's all happened in a short period of time because of some of the significant pain that she's had. So I wanted to share some of this story because I think it just illustrates that point very well. So this is a woman who's a 52-year-old female. She had a history of back injury in high school, and since then has had episodic low back pain. When she came to me in 2021, earlier this year, she was having worsened low back pain, and she really came because she had been managing her pain at home with a large amount of ibuprofen. She'd also been prescribed Celebrex by her primary, and then ultimately I think was really kind of doubling up on her NSAIDs, taking both ibuprofen and some Celebrex for a period of time because she frankly was having such intolerable pain. So she ended up in a situation where she had GI bleeding and a hemoglobin of 5.6, receiving, of course, multiple blood transfusions and an iron infusion ultimately related to this ibuprofen overuse. So when she came to me, she had already had this hospitalization and her blood was corrected. And again, she was really looking for solutions in terms of pain. She'd seen a pain management doctor some years prior and had reported some improvement, at least for a time, with injections, lumbar facet injections, and had had some prescription medications for a time. When she came to see me, she was not taking an opioid medication or had just been, I guess, discharged with a small amount from the hospital because, frankly, she was now no longer able to take NSAIDs due to the history of the very significant, life-threatening GI bleed that she had. Again, her complaints primarily have been related to low back and radiating to both legs, and at times also neck pain radiating to the arms. I did want to share her MRI just to kind of substantiate that, she does have some reasons to have pain. This is just some of the radiologist reading that I copy and pasted up here, and then this is some of this image. So even if you don't look at MRIs regularly, I think there are some things we can all recognize here. So these are the lumbar vertebra, and this part is the vertebral body. And this part in between, the black with the little gray shadow, that is a healthy lumbar disc. So the black is the disc, the little bit of gray in there is just showing a well-hydrated nucleus. And then here, and this disc is a little less healthy. This disc looks pretty unhealthy, and this disc is less healthy. And so at this level, this is L4-5, and there is something called a modic change here, which is reflecting frankly, some change in the bone happening around this area significant degeneration. You can also see this bright, this is a T2 image, and so the CSF, the spinal fluid, is white. This is a disc that's bulging back into that spinal fluid in this area. Again, this is just one image and the whole MRI requires multiple, but I think this is a good one because you can just really appreciate that she has some real findings. And again, this is why she found herself really using a lot of ibuprofen to cope with this pain. So again, I think where the case, excuse me. In this case, a lot of folks might just be able to start this patient on a medication, have them take it at a stable dose. So for instance, in this patient's case, I think she's been prescribed hydromorphone 2 milligrams 3 times a day recently. And in a lot of cases, that might be sufficient, and the patient might be able to control their pain with that. In this case, this patient has had significant problems even despite that. And she endorsed a loss of control around alcohol use. And so she was finding she was drinking nightly to treat her pain in addition to the pain medication she was prescribed. So obviously this is a risky behavior and is concerning. So I think just again to share, sometimes there's the things the patients tell you and the things patients they don't tell you. In this case, again, her kind of overuse of the NSAIDs manifested in a pretty dramatic way because of the hospitalization and then this alcohol use problem as well. She said she actually checked herself into the rehab. She said she wasn't even drinking every day, but that she was concerned for herself because even though she wasn't drinking daily, she didn't feel in control of it. So we had some interesting conversations about this and that it was eye-opening, she said, to see people with much worse problems, she said, than she had. And so then she came to see me afterward and, oh, well, gee, you're off the opioid medication, so maybe we can just help you get by with this. Without this, no, doc, I'm just absolutely dying in pain. And so we've made sure that she has some of these other resources, including, again, to deal with mood and behaviors. She is seeing a counselor. She does see a psychiatric NP on a regular basis. And at this point for pain treatment, in addition, she's continuing in physical therapy, making plans for an injection. She's had one in the past. And planning also for a spine surgery consult. She's been very hesitant regarding interventions. Even the physical therapy was quite a task to try to encourage her to see that. Try to encourage her to pursue that treatment. But at this point, she is and making some progress. So I think, again, I would share a couple of pearls, just because the patient may have a problem with substances, overuse of alcohol. Again, this patient had shown a history of overtaking non-abusable meds too, overtaking ibuprofen, looking for pain relief. Just because the patient may have a compulsion or some type of mental illness, that may not mean there's nothing wrong with them, right? So this is a woman who also has some significant findings on her MRI. I wanted to share those with you just to, as a reminder, just because somebody has a problem, whether it's a mental illness or anxiety, something that may be driving certain behaviors, that doesn't necessarily mean there's nothing wrong with them. And I think this is something we see where providers sometimes will dismiss patients, or it can be tempting to dismiss patients at times when their behaviors look in a certain way. Of course, it's incumbent upon us as healthcare providers to investigate patients' complaints to the degree that appears medically appropriate. So I wanted to shift gears now toward some discussions of buprenorphine. I've got 2 cases and then a few slides to talk about the mechanism of buprenorphine, overall kind of what it is. And again, I'm aware that our audience is kind of a mixed group of folks, of prescribers and non-prescribers. So I'll try to make sure that this is something that everybody is able to follow. But I think anybody who's interested enough in this topic certainly is in the healthcare space and possibly in the addiction or pain management space for sure. So I wanted to share a little about patients on buprenorphine for pain. I've got kind of two examples. One is a patient who's opioid naive, started on buprenorphine, and we'll talk about this molecule in general and some of what prescribing it looks like in patients. So I can think of this woman that I see who's 42 years old. She has Ehlers-Danlos syndrome, which I've abbreviated here as EDS, and joint hypermobility. She's had multiple spine surgeries in the past, including a release of a tethered cord, which is an associated problem with the EDS syndrome. She has a history of anxiety, and she has a history of childhood sexual trauma that she's been very forthcoming with, because she's been very forthcoming that, she does feel like it impacts her pain and her experience of anxiety and feelings around her body. So frankly, we feel like she has sort of multifactorial chronic pain. She has failed many non-opioid treatments, but at the same time, really isn't, again, in the discussions we've had, hey, I don't, want to take an addicting medicine if I am able not to. What are my options? What are the things I can do in terms of medication, etc. In her case, also, she's in counseling, follows closely with primary care to try to handle those other aspects of her, mental health and overall care plan. And so in this patient, we discussed potentially a trial of a buprenorphine buccal patch twice a day, and we'll take a minute and kind of discuss what that is and why you might choose it. So buprenorphine is an analgesic. This is, most of us are familiar with buprenorphine's different forms here. And it was, again, initially discovered or synthesized in the 1960s. It was released initially as an intravenous opioid analgesic, and then in 2002, the FDA had approved sublingual buprenorphine and classified it as a Schedule 3 opioid. In this period of time, the X waiver also came out and allowed patients to be able to prescribe buprenorphine for opioid use disorder, or excuse me, for opioid dependence. And so that's really when we talk about buprenorphine, I think it's important to think about the indications for it, because different formulations of buprenorphine have some different on-label indications, and it's kind of important to use those and know which one that you're using. And why does that matter? That matters really just because if you are prescribing some of the formulations that are indicated for opioid use disorder, the regulations do suggest or do require, they don't suggest it, the regulations do require that if you're writing an opioid for opioid dependence, that you use your DEA-X waiver. And again, as Bridget referenced early in this lecture, if you are considering or need to get a DEA-X waiver, Max does offer trainings in that regard. You can find them through the website. So buprenorphine works differently than other opioids. So it was synthesized just in a lab looking at, hey, what are some more novel opioids we could make? Are there ways we can, I think the holy grail of pain control would be, hey, can we make something that's as powerful as an opioid analgesic, but that doesn't have addictive potential and or side effects like respiratory depression, dysphoria, some of those significant side effects that are limiting for opioid medications. If we could find something with powerful mu analgesic activity, but without those other things, that would be tempting. That would be great. So buprenorphine works pretty differently than other opioids. The buprenorphine is a partial agonist. So this is showing mu opioid effects, or how much it, say, turns on this mu opioid receptor. So the buprenorphine turns on the mu opioid receptor part way, but it doesn't turn it on quite as much as a full agonist like morphine, methadone, etc. And as you go up in dose, then that opioid effect goes up as well. However, there is more of a ceiling effect to respiratory depression in particular with buprenorphine. And so this is what you're seeing with this blue line, is that at higher and higher doses, the respiratory depressive effects of buprenorphine really don't increase that much versus the opioid effects that do. I think the other thing that might be a little misleading on this slide actually is that we're not really sure that buprenorphine has that much of an analgesic ceiling, that there does seem to be increasing analgesia at higher doses. But again, there's potential for pain relief with buprenorphine at many different doses, even very low, as we're discussing with this third case patient. So in this patient's case, the dose that we prescribed her was just the starting dose, which is 75 micrograms. This particular formulation that is an on-label for pain, it's not indicated for opioid use disorder. It's a lower dose, right? So 75 micrograms is significantly less than the doses of 2 or 8 milligrams that the buprenorphine for opioid use disorder comes in. So this patient was started on the 75 microgram patch twice a day with excellent relief and functional improvement. She's really been able to do errands independently and cook for herself and things that she was previously just frankly not able to do. So with this, very, very small dose in the big scheme of things of opioid medicine, she's really had a pretty robust response. And I do have a handful of patients, this is not frankly the only one, who with a very, very small dose of this medication have done very well. The range, I guess just for your reference, this buprenorphine buccal patch, the range of doses that it comes in is up to 900 micrograms twice a day. And so if you think about that, 900 micrograms twice a day, 900 times 2 is 1800, which is almost 2000 milligrams, which is almost 2 milligrams. So very close to that 2 milligram dose. That's the lowest dose for opioid use disorder, the lowest dose that's of the 8 or the 2 milligram formulations anyway. All right. So to dive a little deeper on buprenorphine, have kind of a more complex case, just in the sense of working with a patient who had been taking opioids for years and then rotating them to a buprenorphine-based formulation. I would share with you that there is a lot of discussion around this in the pain community and frankly, even among patients. In this case, this is a patient in my practice who has a history of Crohn's disease and had been prescribed Oxycontin 10 milligrams twice a day, describing history of that for about 7 years and taking 2.5 milligrams of oxycodone, like a half of a 5 milligram tablet at night in addition. So this is 22.5 milligrams of oxycodone in a day, or about 34 milligram morphine equivalent. So not a high dose, but even still, he's having a hard time getting this at the pharmacy. So he approached me and the other providers at the practice about transitioning from this medication to a buprenorphine. He had had a family member that did a similar transition and was actually doing as well or better with regard to pain, and had a much easier time getting the medication. And so the patient had never been on buprenorphine in the past and wanted to discuss it. So I think, what are the concerns with rotating somebody to buprenorphine? And I would just maybe reshare this slide for a moment. And if you've taken the X-waiver training, there's discussion of this, that if you've got a patient on a full agonist opioid and you give them a large dose of a partial agonist, that the partial agonist can displace some of that full agonist from the mu opioid receptor and could actually put a patient in withdrawal. So patients can transition from a full agonist opioid to a partial agonist, but frankly, the treatment needs to be customized to their doses and to be monitored closely because there's not just one way to do it. So in fact, and this is the part where it'll be pertinent that Bridget's going to share these slides. I'm going to talk just a little bit about the mu opioid receptor again. And then I've got actually 3 ways with literature references, 3 ways that providers can help rotate patients from a C2 opioid to a buprenorphine-based formulation. So again, to kind of reiterate this mechanism of buprenorphine versus other opioids, we looked earlier at the difference between full and partial agonists in terms of how much they're turning on the mu opioid receptor, right? We already kind of talked about that the partial agonist is only partly turning it on, only part, that the amount of agonism is smaller. And this is showing the mu opioid receptor itself. So it's a transmembrane receptor. And so then across on the inside of the cell, it is a G protein coupled receptor. And so that then when there is action at the receptor, there's a cleavage event that happens. And the way that the action happens is different. What happens to the G protein is different between buprenorphine and the full agonist. So the full agonists are more involved in beta arrestin recruitment, which produces some of the negative effects of opioids, receptor endocytosis and downregulation, which is some of what leads to tolerance. And there is less of that here with the buprenorphine. I think that's worth mentioning. Again, there is not, while the main focus and the most glamorous and exciting receptor for the opioids is probably the mu opioid receptor because it gives such potent analgesia. You know, frankly, it makes the modern age of, surgery and medicine possible in many ways. It also has bad effects like the bad effects are more through these other receptors. They all have problems, but the mu opioid receptor has some limited dysphoria. The other receptors also produce outcomes, including the gamma, delta, kappa, and ORL1. I think this is helpful to think about the buprenorphine binding and the relative effects of different doses of buprenorphine. So there are a couple of things to kind of get your brain around if you're thinking about changing a patient from a full agonist to a partial agonist. And one is the dosing and the way that you're going to do it. The other is kind of your destination therapy and how big that it is. So this is a study that was done on patients with opioid use disorder getting buprenorphines as a maintenance medication. And the green is showing these kind of highlighted areas are showing unoccupied, and not just the green, I should say, but even up to the red here, binding potential of mu opioids. So there's all this unbound substrate in the brain if a patient's taking no buprenorphine at all. So those are like control patients. And then a patient taking buprenorphine 2 milligrams, 16, 32. And so the numbers that have been derived from this is just a really powerful visual representation of it. But that patients taking buprenorphine at 16 or 32, they have almost all of their opioid receptors bound. And in fact, the numbers that are usually associated with 16 milligrams and up is usually 92 or more % of the mu opioid receptors are bound and strongly bound. Buprenorphine binds strongly and stays on there for half-life of around 32 hours, stays on there a long time. And at this 2 milligram level, which is lower, it binds some, But you could have a patient taking buprenorphine 2 milligrams once a day, and in that patient, they would have about maybe 40% of their opioid receptors bound. So you could imagine where if you had a patient who took this 2 milligram daily dose, and they still had about 40% or just maybe half of their opioid receptors left, that a patient like that could take an additional opioid analgesic for pain and get some benefit out of it. And I think that in that case, well, I'm sorry, I want to kind of talk about this. Yeah, I'm sorry, I lost my train with the case 4 here. So I want to kind of turn our attention back to this case where the patient, again, was choosing to stop a C2 opioid and wanted to transfer to buprenorphine. So we talked about these few different ways. Could we do it with a buprenorphine buccal or a transdermal patch, a generic buprenorphine that's off-label for pain? We talked about the different ways to do it. And frankly, some of the question in terms of, say, choosing your dose has to do with this and, how much opioid agonism do you think that your patient needs? There's not a strict conversion factor or an exact number of buprenorphine milligrams to transfer a patient onto. It's frankly a process of choosing something, trying it out, and then adjusting, like so much of medicine is. So this is just, again, some of those benefits of buprenorphine. So with this patient, we looked at some different options about how do we get you to go on to this. I tend to, more often than not, for a patient like this who has been on a C2 opioid and wants to rotate, I would tend to offer them a starting prescription, maybe 2 milligrams 2 or 3 times a day, and then try titrating or increasing up to, the way I'll often write it is like an 8 milligram patch or film, and then using a half twice a day or even 3 times a day if needed. Now, in our electronic medical record, it makes the most sense to use the F1120 diagnosis, again, which is opioid dependence. In our, I would just share this because I've had patients, or excuse me, I've had prescribers ask me this in the past about diagnosing patients with, can I write this medication if the person doesn't have opioid use disorder? In my system and the way that I read the regulations, to my understanding, this is the buprenorphine medications are generally approved by the FDA. The 2 and 8 milligram formulations primarily are approved for opioid dependence, and having a opioid use disorder is not specifically required. I think an additional consideration would be to kind of clarify in one's own mind, if you were a prescriber for this type of patient, and, if you've treated patients for pain problems in the past, you may know that just because you think that something will work for a patient or that they're going to get relief from a certain intervention doesn't always mean that they do. And so I think it's worth thinking about for this patient, like this older gentleman, would you be okay? Would you plan to rotate the patient back onto their oxycodone if after 2 to 4 weeks or 4 to 8 weeks, the patient did not think their clinical status was improved or did not think that the new medication was a benefit? I think it's relevant to think about that because obviously if a patient has opioid use disorder and you make a choice to rotate a patient to buprenorphine because of opioid use disorder, that's a very different scenario versus an elective change where you've worked with a patient, the patient has made a choice. So I think that it's worth getting that clear in your own mind and probably communicating that with the patient. and that would work both ways, obviously. You know, I've had also patients where I've said, hey, I can still treat you, but if I still treat you, you know, because I do think you meet criteria for opioid use disorder, you know, I've had times where I've told patients, because I do think you meet those criteria for opioid use disorder, we're going to switch toward buprenorphine and we would not go back. You would need to, of course, communicate that as well. And so then in this case, this 77-year-old gentleman who'd been on 35 MME, he was able to transition actually very successfully. Ultimately, he worked up to 12 milligrams 3 times a day, and he was still on a stable dose a year later. I'm going to skip ahead to a slide at the very end that's pertinent here, rather than have to work my way to it. This is from a study. This is from a study by Dr. Rosen, and just looking at prescribers of buprenorphine for chronic pain. Are they waivered? Are they not waivered? Where do they start? Where do their patients end up? And I think it's just instructive to see that, you know, these folks, you know, very many of them in this 12 to 16 milligram range would encompass about 50% of those prescriptions for chronic pain. So just so you're kind of aware of clinical experience out there, it's not just me saying it, but this is what you're seeing in other prescribers as well. But those would be common doses where a patient might have an effective dose for pain and be able to maintain it for some time, I think is the clinical experience that you'll see in the literature. All right. One last case where a patient, where we felt like the risks of the chronic opioid therapy were outweighing the benefits. So again, this is basically a patient who did come to exhibit characteristics of opioid use disorder, and we did end up diagnosing him with that. He was just really unable to manage the medication in a way that he wasn't running out on a regular basis. He had never had a urine drug screen that was positive for non-prescribed substances, but he was pretty regularly needing more medication than prescribed, and really, despite trying to titrate or increase within reason, you know, we were really never able to find a dose that was manageable for him. He had some significant workup for rheumatologic disease and other inflammatory issues to try to rule in or out any of this, to find out if there was anything else treatable, you know, from an orthopedic or pain perspective. He'd had many consultations without, unfortunately, any other treatable problems. So again, in terms of sharing the slides, some of this material would be potentially useful for reference if and when you're helping a patient transition. Again, whether it's for pain or for opioid use disorder, the thinking really is the same, and the process overall of potentially helping the patient transition as painlessly as possible if you were working with a patient to decrease C2 opioids and get onto buprenorphine. So again, when might the risks of opioids outweigh the benefits? Low functioning, persistent moods, et cetera, and frankly, opioid use disorder. This is a general schema just in terms of continuing to prescribe opioids for chronic pain. And it incorporates this Bravo method, which is in a subsequent slide that I think is worth bringing up. And if the benefits are outweighing the risk, then to continue reassessing and prescribing. And if not, then to assess if the patient does or does not meet criteria for opioid use disorder. And if they do, transitioning to buprenorphine, and if they don't, likely slow taper or transitioning to buprenorphine would be recommended interventions. And so this Bravo is a mnemonic for broaching the subject with empathy, risk-benefit assessment, addiction assessment, velocity and validate, not going too quickly, and then making sure to incorporate other strategies for coping with pain. And frankly, these are things that probably are part of your practice regularly if you are treating patients with pain, but they are particularly important as you're working with patients in tapering. And again, if they're not able to taper, then these kind of ideas that, well, that could be one of two things. It could be opioid use disorder, or it could be prescription opioid dependence. And either way, transitioning to buprenorphine or slowing down the taper are the main strategies. And so this is the part where I'll bring up these kind of 3 strategies for titrating a patient from a C2 opioid onto buprenorphine. So the first one is the one called Bernese style microdosing. And so it takes its name from this paper in 2016. And these folks were from Bern, calling it the Bernese method, and published it. The idea behind it is that it can actually be used not just in patients taking opioids for pain, but in fact, it's also been offered for patients with, say, opioid use disorder that are continuing to use illicit opioids, street opioids. And the idea is to have the patient actually continue those opioids early on and just load up these little amounts of buprenorphine into the body. And so this is a graphic representation of, how to take these, tiny little amounts of basically getting 1 milligram of buprenorphine in the body, and then getting 2 milligrams in the body, and then getting 3 milligrams, et cetera, from there. And that's this Bernese microdosing. And during these first 4 to 5 days, still taking the opioids. Of course, this protocol can be adjusted to the needs of your patient, but I think this is a really helpful framework. This is a different schema using a transdermal buprenorphine patch. I personally I have had patients where I've tried the Bernese type of method with some success. I have not done this method with the transdermal buprenorphine patch. It's very appealing as sort of a bridge where you could have the patient just taking their regular opioid for a day or 2, decreasing, and then starting the sublingual buprenorphine. And because, again, this Butrans patch is such a small amount, this one that's available by prescription here in the US, it could just be put on as that's your microdosing in the background, getting things started. I think the challenge with this is frankly getting this transdermal buprenorphine approved by insurance. I think if it were readily available, this would be a more realistic option. But given that it needs a prior authorization commonly, this is not a popular version in my experience. And then finally, I have some 2 slides of a different type of protocol. So I said there were kind of 3 ways that, that I can give you some documentation on converting from full agonist opioids to buprenorphine. These 2 slides are depending on how much the patient was on before. So under 90 MME, which would be kind of anything low, medium, borderline of high dose opioid therapy versus high dose opioid therapy. So say our patient, the 77-year-old man earlier, would meet this criteria and these couple of different ways you could do it. Again, starting the transdermal patch, if you could get it, these would be on-label ways to do it. Or if you were to want to use the buprenorphine film, this is how it could be adjusted day 1 to have some small doses and then increasing as needed. For these patients on higher doses, and this is the real challenge, and I have done this with patients, and I do tend to tell them it won't necessarily be easy having them for the first day, getting into at least a little opioid withdrawal, and then starting these very small amounts of the sublingual patches up to 8 milligrams day 1, and then adjusting in particular over the first week. When I've done this with a patient, I've definitely done, a follow-up within a week's time, like a Monday, Friday, or a Monday, Thursday, to try to check in with their progress. This is that slide that of destinations, kind of where patients end up if you rotate them, or actually, excuse me, this is not even just for rotating, but for any patient prescribed buprenorphine for chronic pain, what does practice look like? Again, a lot of doctors, a lot of prescribers, about 50% in the 12 to 16 milligram range. So I want to wrap that up and give you our contact slide. I'm happy, I see it's 1 o'clock already. I can stay a few minutes and answer some questions, and we would be glad to hear from you at Max if you'd like to send us questions, clinical challenges. We would be glad to help.
Thank you so much, Dr. Merritt. That was a great presentation. We did get one question so far. Please put your other questions into the chat or the Q&A if you need to log off. Oh. Can everyone hear me?
Mm-hmm.
Okay. If you need to log off or anything, we are happy to follow up. But Max asked, does buprenorphine cause less opioid-induced hyperalgesia or tolerance than other opioids?
We think that it does. I think opioid-induced hyperalgesia is, there's not great literature on it, but it does seem to be real. And it's probably worst at high opioid doses of the C2. So things over 200 MMEs are particularly ripe to develop this problem where someone is possibly on quite a lot of opioid analgesic and still has significant pain. And yes, I think due to, and in fact, why do we think that is, maybe is the follow-up question, probably related to some of these different effects on the non-mu opioid receptors. So the lesser opioid-induced hyperalgesia, and we do think it has a sustained analgesic effect over time, are probably related to these kind of unique qualities of buprenorphine versus maybe some of the other opioids.
Okay, great. Thank you. Max says thank you as well. Mm-hmm. Any other questions, please feel free to put them in the chat. Dr. Merritt is giving us her time, just giving us a couple more minutes, so plenty of time to ask questions. While we wait for any more to trickle in, I'm just going to go over some last minute housekeeping items. So once you exit today's webinar, a survey will pop up directly in the WebEx browser. You can fill out that there, and then you will be sent your CME or CEU certificate within 1 to 2 business days. If for some reason that survey does not open, or you accidentally click out of it, you will be sent a link to complete the survey through Qualtrics. That just may take 1 or 2 days because we have to process the ones completed through WebEx first. But that'll be going to the email that you registered with. You also should have already received an email with the slides. I sent that about 3 minutes ago. If you did not, please feel free to reach out to Max Training at som.umaryland.edu. Also, as you can see on the screen, there are all of the Max contact information. Please reach out to us with any clinical calls, any questions related to substance use disorder or pain management or any type of substance use disorder. We're here to help. Looks like we just got another question. I've heard that TID dosing tends to be more effective than BID in treatment of pain disorders. Do you agree? Also, can you comment on using total daily doses greater than 24 milligram buprenorphine regarding safety and effectiveness?
Mm-hmm. Yeah, I can't comment too much on total daily doses over 24. In my practice, I personally don't prescribe it, and I think it's really just the nature of my practice in an outpatient clinic, and that is staying at 24 milligrams is more of an on-label type of application. I think there is some concern in regards to maybe diversion at higher doses. So I think just as a prescriber, if you were to prescribe, more than 24, one of the concerns, one of the things you would want to be particularly diligent about might be, what are your controls in place for diversion? Are you, is it shorter prescription windows? Do you do film counts or anything like that? What are the ways that you're mitigating that risk? In terms of TID dosing, yes, I would say that is also the teaching I've had. And I think it kind of parallels the idea of like split dosing for methadone or higher, um, more frequent dosing of some of these long-acting medications for pain. And in the case of methadone, I think it's around metabolites that only last so long, and that these analgesic metabolites are up front. Kind of the same idea with the buprenorphine. If you're looking to just avoid withdrawal, the half-life of buprenorphine is long enough such that at 24 to 32 hours, depending, it's going to stay in your system, and you can dose it just once a day if it's just about avoiding withdrawal. But yes, to my understanding, that's been my experience as well, in working with patients and in the reading that I've done as well, that more frequent dosing, so often BID or even TID, will help that. In the case of, say, a TID dosing, just a practical matter, if you're thinking about it, I think the example I gave, my patient taking 4 milligrams would be buprenorphine TID, and maybe he's written as an 8 milligram film where he takes a half 3 times a day. Just as a practical matter, that 1.5 films a day is easier to get approved by the insurance versus sometimes a TID might be more likely to favor a prior authorization. Some of these plans will have quantity limits and things that you need to work with, and so depending on that dose, it might be a consideration.
Okay, great. Max says thank you again. Max, if you have any follow-up questions, please let us know. I'm not seeing any other questions in the chat. We'll give it a couple more minutes. But if you can't stick around with us, please feel free to log off. I know we're a little bit over time. And just once again, today's webinar is recorded. So if you think there's anything that you missed, maybe you logged on a little later, that link will be up on our website within the next week.